Delighted to be here as part of our Change My Mind series with Emma Holly. She's got into the hot seat, and the concept is you can't meaningfully alter tissue with manual therapy. Change my mind. So I want to throw it over to you. What's your take on that?
Thanks very much. Well, it's a really important question that we really should be asking if we're working as physical therapists. So I do think what you need to do is think about what effect you're having on the body when you touch it, and what evidence have we got to show that there has been changes. So particularly the area that I specialise in is working with scar tissue, and one of the things that you could liken the possibility of manual therapy being able to change an area around scarring is to look at what we can see with fluoroscopy guided lymphoedema research. So what they've been doing is been able to see how when manual treatments come on, we can impact lymphatic flow, directing the flow of lymph and improving the flow of lymph with that hands-on touch. If you're able to change fluid at the level of the lymphatic system, and we already know when we're working with soft tissue treatment that we get an erythema response, so we get a reddening, particularly over areas of tightness where we've got tightness through the fascial system, through the skin, potentially through the deeper structures as well. What we're getting then is not only potentially that when we come hands onto the body, we're affecting the lymphatics, which we're able to prove through this fluoroscopy guided research that's been going on, but also we can visually see that there is an erythema response, and all of the sort of cellular changes happen because our body systems are constantly responding to stimulus. And there's a really great paper that came out this year called Mechanobiology in scar tissue. It's quite a lengthy name of the full study, which I don't have to hand, but I'll certainly send it to you if you wanted to link it at the bottom of the podcast. And what it looks at is the research to show when you change tensional forces over a scar, you can actually change the development of the scar tissue itself. So there is more and more research showing that tensional forces, hands-on touch, touching the body and moving the tissues manually do have an impact. And right from when embryos are forming, it's the tensional structures around that allows that embryo, as it grows, the cellular structures form into different parts of the body depending on their placement as the cells multiply. So it's a fascinating topic.
And how is that different to when that tissue moves because we move?
Yeah, really good question, really relevant question. And again, you can look back at those research studies with the lymphatic treatment, is that when you move your body, there is restrictions over the direction and the load that will happen given any body part. Whereas when a manual intervention comes in, we can put stress through the tissue or move the tissue in ways in which during your everyday movement, you're not able to mimic. So we can select smaller bits of tissue by breaking up body parts and then focus techniques on those, either forces, directional forces to come in towards a tight area, forces coming over a tight area, and the way that the body tissues will then respond to those tensional structures is what I'm particularly interested in when I look at my scar tissue treatments. It's all about those forces on the tissue.
So when we can be more specific, say, with our hands than we might be when we're moving, but what's the difference in why you would then be more specific over that? So let's say something like lymph you've mentioned. You can make sense of the muscle pump action that can occur that can really promote lymph drainage. You would want to combine that, wouldn't you? You'd combine active and passive techniques.
Yeah, no, definitely. I'm very much of a view that it shouldn't be a single modality that you would use in any setting to try and improve somebody's quality of life and quality, particularly if they're experiencing something like pain in any part of their body. So obviously with my specialism, if somebody's had let's say an abdominal surgery and they've got ongoing pain, they're struggling with certain movements, certainly you would want to combine hands-on treatments, or you can use mechanical devices which stimulate the tissues in a way which their everyday movements aren't able to, and then you'd definitely be looking to combine those with a rehab program so that they're doing exercises to complement that.
When with Julian Baker earlier, I, especially for the sake of argument on the detail. When a word like change is something that I'm going to just definitely be able to grant, right? If we don't be more specific with what we mean by that, then even erythema, like you're mentioning, which is of course, who would deny that that manual techniques can then produce superficial redness at the very least, right? So we know that that's happening on capillary level changes. Meaningfully is where the magic happens on this debate, really, is then all the things you're describing there. I'd be interested in seeing what it is that you feel is particularly meaningful about that, and what do you think about when you think of that word?
Well, certainly I think in terms of being able to have a really fine palpation level to understand what level of tissue it is that you're wanting to generate a change in, to make sure that you're stimulating at that level. And then the assumption that you have to make if you are looking at how any physical treatment, whether it's a manual therapy or an exercise movement, is that loading and moving through a tissue area does generate a response in the body. And so it goes back to that idea of the stress on the cell does have, it's been evidenced to have a response in how those cells interact with the cells around them. So it can have an impact on the fibroblasts, which are obviously the building block cells. And so stress at a cellular level creates a chain reaction event at a cellular level to either generate more tissues, to generate more activity in an area, whereas an area that's left passive, that isn't moved, that's immobile, whether it's through a manual intervention or through exercise, we know that that is less healthy. That part of the body becomes less healthy. It becomes, we want to encourage fluid flow, at every level to keep an area moving, because we know that movement is good.
Direct perpendicular pressure is something that then we can understand the physical forces then and how that's been transmitted into what layer of tissue. But actually the surface between the skin and the fascia is frictionless, and that's been shown on several studies on just raw physics rather than it being physiotherapy or massage therapy type research. Therefore, the directional preference of that and the specificity of those treatments, how would the forces on a frictionless surface be transmitted deep into any layer of tissue beyond skin deep?
If you think about, I can only talk about my level of specialism, where I'm looking specifically at working at scar tissue, which is where there's been a connective tissue repair from skin level going down deep. So in the case of scarring, you have got a continuous connection between the skin level, which does make it quite different. And I do find myself that scar tissue, when I started doing manual modalities on that compared to when I'd been a soft tissue therapist doing massage, because of the difference, because you've got connective tissue from deeper structures through the fascia up to the top of the skin, you certainly get a much quicker response, because I think you're able to translate that. The connective tissue repair is translating from superficial down to deep in a way that it doesn't in healthy skin. And I think
I suppose when it comes to, say, scar treatment, and we were to then, we're talking about at a tissue level, intervention has then changed those tissues. If we're thinking about what is meaningful, we then might think that it's meaningful for the patient for them to have had a positive response to it. But how are we measuring that? If we know that then there's people that have got really deep, tethered, grotty scars that are old, that don't hurt and don't affect them. So you'd think that
But then why would you want to treat, you'd only bring somebody in for therapy treatment if you were having an effect. And certainly you've got to think about what are the symptoms for those scars. So the things that I'd standard check is sensory dysfunction, whether or not there's ongoing pain issues, whether or not there's bloating, if it's abdominal, could be edema as a response to the scar. Then there could also be tightness and restricted movement. So you've got to break down the different elements of how a scar could be affecting that individual, right. And then think about how you would. Obviously, if you've got edema occurring, let's say you've got a scar on the leg and you're getting edema build up beneath the leg, the scar tissue could then be causing a physical barrier because it's less functional. The return flow is less functional through it. Therefore, if we come on with a manual modality, actually rather than pushing down into the tissue, we need to be thinking about lift. We need to think about trying to increase the interstitial space in order to promote return flow back towards the heart, back towards the core centre. Similarly with things like people who've got sensory dysfunction, we need to think about, well, what level of tissue do you have sensory dysfunction? So if they're missing light touch, you don't even want to be thinking about going particularly deep into the tissue. You need to think about lots of really very superficial stimulation So at skin level is where you need to give that superficial stimulation to try and generate a tissue response at that level.
So is it your opinion that then there is a correlation between the tissue characteristics local to a scar and the symptomology?
Yeah, I think that when you find you've got scars which you can clearly, tissue characteristics, you can observe puckering, you can observe thickening and fibrosis, then scars which are visually and palpably inferior are much higher likelihood of creating physical symptoms compared to a flat pale scar that's highly mobile over the area. Then I would say the likelihood of that presenting with complications and impacting on a more global level is going to be very minimal. So what you're aiming for is at that level of tissue that you've got good movement and that you've got symptomless scars. That's what we'd like to achieve. I'm
not aware of, I mean, this a lot of people have got a lot of scars, and I'm not aware of that evidence that would show that, despite the fact that I'm sure that it's a fairly straightforward thing for us to study. And one of the things that I would be fascinated by is then...
So can I just pull you back on there? So you're not... So there's
the correlation between tissue characteristics. Like, we're not even talking about whether we've changed them or not, right? But like, you know, grotty. Call them grotty scars is wrong, but I mean, like you said, both aesthetically and palpably inferior is what you said.
Yeah.
I'm meaning that then, as clinicians, we wouldn't see those that are having these that are unaffected by this. So we have such a biased sample.
Well, not really, because you could well have. I mean, how many people are walking around with scars? So if you're doing a proper physical assessment, you should be checking whether or not somebody's come to you for a recent back injury, a shoulder injury. In your medical history, you should be checking whether or not they've had any previous surgeries or injuries, and that should be, that should be part of a standard intake.
But if someone sees me for a frozen shoulder and they happen to have had an orif on their contralateral ankle, they're unlikely to mention that unless it's particularly recent. I ask you any recent surgery or fractures, but if they don't mention it, that might be what would be palpably and visibly an inferior scar as we described it, but it's something that's otherwise irrelevant. They completely resolve their symptoms.
You think it's irrelevant, but what often happens, and that's what I've been talking about at the expo today, is the fact that actually through the chain of movements over a longer period, if one part of the body is not moving as well, you often, and particularly if you've got numbness around that area, where the person may present with ongoing injuries could be through the chain of movement rather than at the injury site itself.
Why would people move? The existence of people that move badly and have bad scars that don't have pain lifelong, how do you square that circle?
So the way that I do it when I'm teaching is I say to my class, look, everybody stand up, and just if you fixate one ankle and then try and rotate and reach across in the other way, where do you hurt? So if the ankle's not moving so well, it's less likely, if you're holding that ankle stable and not allowing it to twist as it would healthily do with movement, you feel the pain in another part of your body. So that's where I'm talking about, if scar tissue is causing a restriction in one area, it isn't always that area that presents.
Yeah, sure, but I suppose if people are, when they don't have symptoms, right, when people are moving what we call badly in this instance, why would that not manifest itself? Why would that not show itself in time? Right, so when people are moving badly, due to scars in this instance, why would there be asymptomatic people?
But they aren't going to be, because the body is absolutely phenomenal at coping with injury. That we are great at adapting, and that's what you see. If you have somebody who has, I treat I work specifically a lot with people who've had breast cancer. So when you get your clients into clinic and they have got such restrictions, cording and other really common complications after their breast cancer surgery that they don't have full mobility through their arm, what they start doing is they start bending their back to get full extension through there. So that person, if they continue to do that, how are they going to present in a physiotherapy clinic? They're going to say, I've got back pain. Because if they can't feel the pulling at their arm and they're compensating for that lack of movement, they're not aware of it. You know, this is the point, is that we're the ones who are supposed to have the physical expertise in looking at how the body connects up through and how one thing connects to another.
Right, well, I mean, we've just had the siren's gone off for us.
Yeah,
we'll be
we've
kicked
got to
out.
leave it there. I can
kicked
see
out.
we could talk for a little bit longer.
We'll be kicked out soon. I will admit that I think that a lot of the things that clearly what you feel are the centre of the bullseye for MSK pain, I think are somewhat incidental. I also don't think necessarily that you or anyone is doing with their hands what they quite think it is. And admittedly, I will admit I haven't quite changed my mind. Where I do think it is interesting.
Could I invite you to take a look at the before and after photos? Unlike other physical therapy treatments, when you've got scar tissue adhesions, you can physically capture and photograph a difference of before and after, as well as seeing changes on
there's no control group to those, though, is there?
And there is also a study that I've been involved in where it looks at the positive effects of treating scar tissue.
But the before and after photos of my recent weight loss, for example, they don't necessarily imply causation to what was done. There is no control group to that, is there? So we have to look at the wider data. So I think that whilst of course that can be interesting, and what I was just going to go on to say is that I think that I would like to look further into this, because I think that scar tissue is an area, especially developing scar tissue, is an area in which I actually think that is area where it's more likely that you will make meaningful tissue changes than it is, say, stubborn scarring or to say otherwise uninjured tissue. So I actually think that is an area that I do want to look further into, and I really firstly appreciate you engaging in this, and we could talk forever, but yeah, we're out of time.
And I do invite you to have a look at that study about mechanomodulation, which
Absolutely
is really looking, and there's quite a lot of actually in vitro studies of scar tissue and adhesion formation and how tissue tension can have an impact on that. So there is proper scientific study in this particular area, which is really great, and I'd be happy to share with you.
And we'll certainly link to that for sure. No, thanks a lot. Cheers for your time, Emma.
Great.
Take care.
Cheers.
Bye-bye.